This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. For those of you new to us, I'm a med-peds trained pediatric hospitalist here at UPMC Children's Hospital of Pittsburgh in the Paul C. Gaffney Division of Pediatric Hospital Medicine. We have been coming to you since October of 2016, which will be important for this episode, and you'll see why. Talking about topics for pediatric hospital medicine related, whether it's from the content specifications from the ABP or things that have popped up, and a great example is COVID. And we are here today with a similar thing. Just a reminder, if you're looking for CME, it's courtesy of the University of Pittsburgh, so thank you, University of Pittsburgh, and it should be at the bottom of the podcast description. Now, if you're like me, you're in the hospital, you're working, and all of a sudden, your census has exploded. And there are a lot of kids coming in with reactive airway disease and asthma. And if you've been doing it as long as I have, which is a sad statement to say out loud, but if you've been doing it as long as I have, this is shades of 2014 and 2016, and you're having flashbacks of that. And you're wondering, which I was wondering, oh my God, is this Enterovirus D68? Is this back? Is that what we're seeing? Do I have to worry about acute flaccid myelitis? All of the thoughts are in your head. And we are here to help you with that. And to help us with that, we have friend of the podcast, Dr. Megan Culler Freeman. You all remember her from such wonderful episodes as almost everything we did on COVID. Dr. Megan Culler Freeman, MD, PhD, is a pediatric infectious disease attending at the UPMC Children's Hospital of Pittsburgh in the infectious disease division. She completed her MD and PhD degrees at Vanderbilt University, where she earned her PhD studying coronavirus in the laboratory of Mark Dennison. Current research is on Enterovirus D68 and how it causes the severe presentation of acute flaccid myelitis. She's growing her laboratory team, so if you're interested, please contact her. So, Megan, thank you for joining us again.
Thanks so much for having me. I'm delighted to be here.
Based on your research topics, Enterovirus D68 and coronavirus, we'll be talking to you a lot.
Happy to help. You know, I never intended to choose the viruses that ended up being the hot big thing, but somebody told me that I should play the lotto, and I haven't taken them up on that yet, so we'll see how that goes.
Really? You really should. You really should. Now, let's do our disclosures before we get into Enterovirus D68 and if it's back or not. I will go first and kick it out to you. I'm on a meningococcal vaccination and immunocompromised pediatric patient advisory board at Sanofi Pharmaceuticals, which should have no relation to what we're talking about in this episode.
I have nothing to disclose.
All right. So, Megan, am I right? Is my feelings right that we are seeing Enterovirus D68 again with all of these reactive airway disease and asthma exacerbations that are filling up our hospital?
Your feelings are right. So we know that Enterovirus D68 is back in circulation again, and that's both locally here in Pittsburgh as well as around the country.
Now, Enterovirus D68, from what I remember from our last episode, was this is an older virus. It's been around since the 50s, but something happened to make it attack, for lack of a better term, people who are likely or have a predilection to wheeze. Is that right?
So they actually isolated the first isolates of EVD68 from some children with pneumonia in 1962. So you're very close, but mid-century. The furniture probably looked very similar. And then we didn't hear much about EVD68 until 2012, 2014, when we started seeing the EDs and the children's hospitals be filled with people with having asthma exacerbations, both those who had a known history of asthma and also those who hadn't necessarily been known to wheeze before. So this disease is a respiratory disease, which is a bit different than some of its enterovirus family members, but it tends to cause that severe presentation, which is why we started hearing so much of it over the last 10 years.
Yeah, enteroviruses, the way we learned them in medical school, is they're hand to mouth or fecal to oral route for transmission, but this one is aerosolized, right?
So yeah, this is actually what my kind of the beginnings of my foray into Enterovirus D68 was all about. So many enteroviruses, and we'll use the classic example of Coxsackie virus, the cause of hand, foot, and mouth disease, the scourge of daycares and maybe parents everywhere. So that is a classic enterovirus. It is, the majority of it is fecal-oral transmitted, which means that good hand washing is critical to kind of break the cycle. So one of the things that had been determined in the early 2000s about EVD68 is that when scientists were working with it in tissue culture and cells in the lab, they noticed that it tended to prefer to grow at lower temperatures, so 33 degrees Celsius instead of 37. And it also could not withstand acid as readily as some of the other enterovirus cousins, leading them to hypothesize that maybe it wouldn't be able to survive in the gut because it would be inactivated by the patient's stomach acid. So most of my fellowship work actually was looking at a variety of different contemporary isolates of EVD68 and testing them in a variety of primary cell culture models, so both the respiratory epithelia and also the gut. And what I learned is that while the historic isolates from the 60s, that was absolutely true. They couldn't withstand higher temperatures and they couldn't withstand acid. Some of these more contemporary isolates actually can stand some of those conditions. So maybe it's not as black and white as we used to think, but I do think that the majority of this virus is spread via the respiratory route.
Those sneaky buggers, they got better at what they do. Now, in the past, when we've had Entero D68 causing respiratory issues, it's been like 25 to 30% of all causes of wheezing that have presented during those time periods. Do we have any data in terms of numbers? Is it similar this time or more or less?
So what I can share about some local surveillance efforts that are plugged in with some of the more national surveillance is that we have been seeing an uptick in the percentage of children presenting with respiratory viruses that specifically are due to EVD68. And I don't know the exact percentage threshold, but I do know that it's been climbing, and that we have been hitting nearly those targets that you've been talking about.
Now, the thing we worry about Entero D68, besides it filling up our PICUs and our floors and our EDs with kids who need wheezing, and the concern for too many patients that a hospital can handle, is acute flaccid myelitis, right?
Yes, exactly.
Our generation's polio, is that a fair way to put it?
I think that's absolutely fair. So poliomyelitis is caused by the poliovirus, which is actually in the same viral family. The family of picornaviruses are very small RNA viruses. Enteroviruses are referred to as non-polio enteroviruses, as just to differentiate them from polio. But absolutely, we started seeing this association between the times, the seasons in which EVD68 was circulating, which is often, August to November in the fall. In 2014, 2016, 2018, we also saw nationally a large spike in the number of cases of children presenting with acute flaccid myelitis, which is a new onset of weakness of one or more limbs, as well as some of the facial muscles.
Now, can you walk us through, for those of us, because in 2020, we didn't see this because of COVID and masking and social distancing. So for some of us, it's been 4 years since we've even really looked at AFM or acute flaccid myelitis. Would you mind walking us through typical presentation, when we should worry about it, and then work up for it?
Sure. So prior to COVID, had seen this virus circulate on an every other year cycle, and it also came with it an increase in the number of kids that presented with AFM, which I do want to reinforce is a rare disease. So the numbers that are associated with it now is a 1 in a million presentation. So it's something that we see, but for those of you, watching your kids come home with colds, it is very rare. There are a lot of colds that are circulating right now. So I don't want anyone to freak out. I just want you to be aware of what to look for. So we were expecting this to come back in 2020, but absolutely, as you said, the non-pharmaceutical interventions we used to stop the spread of COVID were effective against all of the respiratory viruses. And since things have become more relaxed in terms of things like, school attendance, masking, social distancing, any sorts of local rules about that, we have been seeing increased and abnormal circulation seasonality to many different viruses, we've been still seeing RSV circulating here in Pittsburgh, which is insane when you think about it. It's, mid-September and it never went away.
Yeah.
So the seasonality of a lot of things has been different. EVD68 just missed its 2020 season and it waited the requisite 2 years after that, I guess, and came back out in 2022. So things that doctors and parents should be looking for. Oftentimes, the story will be that a child developed paralysis about 1 week after they had a respiratory illness, or maybe others in the family or others in the classroom had a respiratory illness. And the thing that will bring the child to medical attention is that weakness in one or more extremity, plus or minus a fever, will arise, and then that will kind of spark the family to seek care.
So that's weakness in one or more extremity, typically a week after a URI, some sort of respiratory illness.
And it's usually the average age of presentation is 5 years old. 90% of cases, however, in kids under 18. So it really can be any age, but it is often in kind of the younger kids that we look for it.
So now I'm in the hospital. I'm a hospitalist. I am. And I have a kid coming in with right arm weakness. And is it correct that this is more proximal than distal in terms of typical presentation for weakness?
Yeah, so one of the kind of differences between what we've seen with the modern AFM and poliomyelitis is while it can cause weakness of arms, legs, the facial muscles, or any combination of that, it does tend to be more upper body rather than lower body, which I think is a difference from polio.
Okay, so if I have this patient, I'm thinking, I'd like to rule out or consider AFM. What should I do first?
So you're probably going to want some of your friends to help you. And I would say that would include your friendly neighborhood neurologist as well as an infectious disease doctor. They're going to want to get an MRI, which is going to be the definitive test to see if they're able to see any changes in the spinal cord.
What changes would you see in the MRI? And I'm going to add, and are they diagnostic?
So we expect to see gray matter changes in the spinal cord and also sometimes the base of the brain. We very rarely see anything actually in the cerebrum of the brain. So we will see gray matter changes in the spinal cord and the brainstem, but often none more supratentorial. These unfortunately are not diagnostic, but I would say in association with other information that you have about the patient, just paints kind of an overall picture of what the disease process is.
Do we have an idea of how many, what percentage of Enterovirus D68 will cause AFM? So it's of all the kids who get Enterovirus D68, 0.1% will get AFM or something like that.
Oh, I don't have a great number about that. And the reason is when we do surveillance, so the panel that you have access to in the hospital, the RVP, all we see is rhino entero positive. It doesn't tell you if it's a rhino or an entero, and there actually has to be kind of some back deconvolution of samples for them to be able to test that. So the repository nationally that we have the most data for, it's hard to know what the denominator is because I don't know how many of those rhino entero positives actually were EVD68. So, if you have a person that you think has AFM, then their specimens are going to get sent to the CDC. We're going to for sure know that they have EVD68 or they don't. And there's also, as part of the new vaccine surveillance network that John and Marion are the site PIs for here as coordination with the CDC. They test for EVD68 and have data, but that is not, every site in the country. I think they have around 10 sites nationally.
So if I have a patient who has proximal weakness upper body, typically 1 week after URI, and maybe even to paint a better picture, the URI caused them wheezing, needed albuterol, needed steroids, and they're coming out because of the weakness, I'm going to order this MRI of the brain and spinal cord. If I see the gray matter changes, I'm going to be really thinking about AFM. At that point, at Children's Hospital in Pittsburgh, I'm going to call my friendly neighborhood infectious disease specialist. And am I expecting, like polio, this disease will progress and I could have respiratory weakness in a while? Is that what I'm expecting to see?
Every case of this that I've been familiar with, I took care of several of the cases that were here in 2018, and all of, with the exception of maybe one, did spend some time in our ICU, mainly either for monitoring of airway progression or because they needed to have airway support with intubation, and some of them actually did go on to need tracheostomies as well.
Now, in terms of sending testing, we have some people listen to us here at the podcast that are community hospitalists and may have access to an adult infectious disease specialist or a pediatric one by phone or maybe telemedicine. But just for their benefit, what viral testing and are they sending stuff to the Department of Health, or should they just call their local Department of Health?
So the CDC, once this is a reportable disease to the CDC, and they are going to want to work with you to collect specimens to send to them as well as part of their surveillance study. There is actually another national surveillance study and kind of the natural history of AFM study that has multiple sites all around the country that are enrolling. That one is run out of the University of Birmingham. So if you have a local children's hospital, I think it would be worth a phone call, at least to talk to somebody there and see if, they would assist you in management, if that's something that they would want you to transfer their patient or the patient to make sure that they have the appropriate ICU level care, kind of in addition to specimen collection. But I think that there are probably multiple avenues to go as far as that is concerned. And the presentation is highly variable. It can be anything from, just a bit of weakness to the distal arm, all the way to, someone that needs respiratory support. So I think the presentation can be quite variable, and it's all about which part of the brainstem or spinal cord happens to be impacted.
And is there any treatments that I should start immediately if I'm seeing a patient? Is it steroids or anything that I should start right away or think about starting?
So this is one of the things that I really wish that we had more specific therapies to offer. And one of the reasons why I'm so enthusiastic about EVD68 research is that we don't actually have any specific drugs for EVD68, whether it's, in association with AFM or not. The guidelines actually, we have a clinical effectiveness guideline here at the University of Pittsburgh Children's Hospital, and we will use IVIG, but that's not a specific medicine. And there was some animal data that actually suggested that steroids might make things worse. So we tend to not use steroids in these patients.
So we use IVIG, but that's not specific. We tend not to use steroids. It can make things worse. And there's nothing specific for Enterovirus D68 as of yet.
Right. So, when you meet these patients, you're going to have a broad differential. You're also going to be thinking about things like, tick paralysis or Guillain-Barré syndrome or infant botulism, other presentations of kind of the new onset of weakness that you'll want to be able to think through.
Now, you mentioned something earlier that brought up a question. I always thought, and I don't know why I thought this, but I thought it was our hospital that our respiratory virus panel couldn't differentiate rhinovirus from enterovirus. But I read recently none of them can do it well. Is that correct?
So this goes back to how the company that makes the multiplex PCR respiratory viral panel, and there are a couple in the U.S., have decided to include targets. There are absolutely specific tests for Enterovirus D68, just that virus, but it's probably not practical to put those in a multiplex panel with the other, 12 most common culprits of respiratory disease, when this is one that you see every few years, although I would argue one of great clinical importance. But I think that is probably more a function of who decided what primer sets were going to go into that test modality, and not because we're not able to do it.
So now, Enterovirus D68, like parainfluenza 1 and 2, is every other year. Do we have any idea why it does that?
So the best hypothesis for this is about mucosal immunity and waning immunity. So if you think about having a large population, say, we know right now that a lot of EVD68 is circulating. So maybe we have a ton of people that get it. Say 70% of the population gets it. Then that means that that 70% of the population is going to have a great antibody response, at least for a short time, train up the T cells, at least for a short time. But as with many other viruses, especially respiratory viruses, reinfection is sometimes the rule. But I imagine that, at least my theory, is that for at least a year or two afterwards, you have enough immunity such that the virus is not really able to get a good foothold and replicate from person to person in the population. And then as the time passes, not only do you have waning of mucosal immunity for people that were previously infected, but you have a new birth cohort. So all of those babies that were born in the previous 2 years, or in our case right now, the previous 4 years, have no immunity to EVD68, which means that we might actually be seeing a bigger season this year than we have previously because of that naive new cohort.
That makes sense. 2018 was not as bad as 2014, and that was a 2 rounds, 2014, 2016, and 2018. And we've had this 4-year gap, and we're seeing a lot of younger kids. That's brilliant.
And it's interesting, too. And I wonder if this is a function of our surveillance efforts nationally improved. We did have a higher AFM count in the year 2018 than in 2016 or 2014. But I wonder if some of that was probably vigilance and reporting, as opposed to necessarily, a change in the denominator. It's impossible to know.
Well, I hope that's all it is. For everyone's sake, I hope that's all it is. So to recap now, we're seeing more Entero D68. It's been around since the 60s, but it's changed to around 2014. It's causing this reactive airway disease. A very small amount, and we can't say what percentage, but we said the 1 in a million chance of kids that get this disease could get acute flaccid myelitis. We would suspect that typically it's around 5 years old. It's the median age. And they would have weakness, upper body typically, proximally more likely a week after a URI symptoms. And then testing would be ideally an MRI of the brain and spinal cord looking for gray matter changes, in addition to your differential of tic paralysis, Guillain-Barré, and other things that you're going to be thinking about for that patient. There is no specific treatment for acute flaccid myelitis. Clearly, it could progress. So if you're in a community hospital without an ICU, perhaps this is a patient you transfer for monitoring at an ICU level facility. And then, of course, it's a reportable condition to the CDC, so they would like to know about it. So you call your CDC. And did I miss anything?
No, I think that sounds terrific. The CDC actually has a lot of great educational resources on their website. And one of the posters that I've been seeing a lot lately is they call it head, shoulders, knees, and toes. The things to look out for. You want to make sure that your patient can put their arms over their head, that they can shrug their shoulders, that you can pick your knees up kind of to a tabletop position from standing, and that you can lift up your toes. So if you see someone in the community and you're worried about weakness, that's kind of the fast way that you can assess for differences.
Well, that was great. Megan, that was all of my questions. Is there anything I didn't ask that I should have or that you want to discuss?
Yeah, so I think one of the things that has always been a little bit challenging with the association between EVD68 and AFM is that it's been really tough to find the virus at the scene of the crime. So the CDC has been collecting all sorts of specimens. When they can, for your patients of interest, they want a sample of spinal fluid as well as blood, urine, and stool. I'm sorry, that's wrong. They want spinal fluid, blood, a respiratory swab, and stool. So over the detections of all of the viruses that they have looked at, this is over 500 specimens, they have only found enteroviruses in 4 of them. And 2 of those, in the CSF, 2 of those were EVD68, and the other 2 were other sorts of enteroviruses. So it's been very hard to put the virus at the scene of the crime. I think that might actually be for a couple of reasons. One of them is if the person is infected about a week prior to their presentation, then it's going to be a lot harder when you meet them a week later to actually be able to find replicating virus in their nose. So either it's moved on to another site or it's not there in large numbers. But we have, since 2018, had a couple of studies come out that suggest that there are antibodies in the central nervous system that are specifically enriched in patients who have had AFM for enteroviruses. And there also was a New England Journal paper that came out this year that retrospectively looked at an autopsy of a young boy who died of AFM prior to 2012, actually. And they were able to use some of those specimens and go back and stain for EVD68 in the spinal cord and find it. So we are at a point now where I think the relationship between EVD68 and AFM is getting stronger all of the time. There's a lot more data to support its role in AFM, and our job is to be vigilant.
All the more reason to call your local CDC once you feel like you have a patient. So you cut out for a second, but I want to be sure I heard that right. Of the 500 cases of AFM that the CDC has looked at, only 4, you're saying, have found Entero D68 in the spinal cord fluid, in the CSF.
Yes, that is exactly right.
It's a tricky little bugger.
Isn't that sneaky?
Yes.
So, this is like all about what my KO8 is on. So what my laboratory will be studying is how Enterovirus D68 causes AFM.
Well, we appreciate you studying that because we need it, and we appreciate you being on the podcast because we have learned a lot. Thank you so much for your time, Megan.
Thanks again for having me. Talk to you again soon.
Talk to you soon.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, TARCHICHI, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.